Dr. White is the director of the Physical Activity Laboratory at the University of Delaware, which is focused on the study of free living behaviors in the home and community environment and how these behaviors benefit health. The goal of the lab is to develop clinically feasible and practical ways to increase physical activity in older adults, in people with arthritis, and people after total joint replacement surgery. Dr. White is an associate editor for the journal Arthritis Care and Research and an active member in the American Physical Therapy Association. His research is funded by the National Institutes of Health and the Rheumatology Research Foundation. He will present for approximately 20 minutes or so, and then we will have 10 minutes or more for questions and answers as well as discussions. You should type your questions into the chat box, and I will read them off to Dr. White. So with no further ado, Dr. White will now present on improving pain and function with daily walking.
Thanks so much, Leigh, for that wonderful introduction. I really appreciate it. And in the spirit of COVID, I'm happy to give this presentation from the back of my car as I just dropped off my kids from school and have to pick them up shortly. So anyways, it's a pleasure to virtually see many people on this conference, and it's certainly a pleasure to give this talk. And I do want to give a special shout out to the conference organizers for just doing a wonderful job with transitioning this to virtual. I certainly would have loved to have been in Florida on this cold day in Pennsylvania, but certainly this will do. And certainly shout out to Tuhina for inviting me to give this talk. So pain and walking, improving pain and function with daily walking is certainly something that's near and dear to my heart. And I want to start off by just giving some just general definitions of what we typically call physical activity. And physical activity is basically represented by this blue circle as sort of any energy expenditure above a resting level, and features sort of unstructured activities, things that just kind of happen on a daily basis. And this could be things like going grocery shopping, gardening, or taking a walk. But these are sort of unstructured events. Now, exercise is a specific type of physical activity. It qualifies as you expend energy above a resting level, but exercise is special in that it is structured, planned, and reoccurs over time. The reason you want to sort of understand these definitions, the reason I wanted to give these definitions is so that when I talk about different studies, you can understand the distinction between an exercise intervention that is typically planned and reoccurring versus a physical activity intervention that sort of leaves it up to the other people to increase their activity in an unstructured or unplanned sort of way. So the first thing it's important to understand is that walking, why we place so much emphasis on walking, is that walking is the most common form of exercise employed by older adults. It doesn't require any equipment. It is free to do, and most older adults are able to walk. It's also important to understand that that we when you walk purposefully, you do hit what's called a moderate intensity of energy expenditure, which is critical to gain the most beneficial health benefits from physical activity. And that is, again, done when you walk from point A to B, if you walk in a purposeful way. So not a slow shuffle, but walking as you would to walk down the street. And that is just a really important point of reference for people to consider that, some might consider walking as an underdose or a minimal level of energy expenditure, but in fact, it's not, and especially for people with knee osteoarthritis, which I'll get into. So I guess the next question is, is walking actually effective at all for people with knee osteoarthritis? Is it beneficial for pain and function? And I always like to talk about sort of what I call these legacy exercise trials that Steve Messier and colleagues performed over almost approaching 2 decades now. And the first is the ADAPT trial. In this trial, essentially, what Steve did was he took individuals with knee osteoarthritis, and the exercise, this group that was randomized to an exercise group, uh, walked for 3 days a week, and they spent 15 minutes walking at 50% to 70% of their heart rate reserve. Then they did strength training. Then they walked again for another 15 minutes, and then they had a 15-minute cool down. So a total of about an hour per exercise session. They did that 3 days a week, and they also did that for 18 months. So the 18 months is to ensure that enough of a dose was received by the patient. And it's important to note that these trials were not designed to be practical, but rather to understand, does exercise, and specifically in this case, in my opinion, walking, is really beneficial for pain and function with people with knee osteoarthritis. And to date, there was a concern that walking would increase people's symptoms and make their OA worse. And what Steve and his colleagues found was that actually people, especially when you combine this exercise group with a diet group, had positive changes in the WOMAC physical function and WOMAC pain scores over time. And this study was essentially replicated several years later in a modified version where they essentially did a very similar intervention and found positive results for both pain and physical function, and especially among those who received the diet and exercise intervention. So now that there's sort of a positive signal for walking from an exercise perspective, the question is, well, can we, what is the literature with regards to increasing walking, but maybe more from an unstructured way? And the advent of pedometers and specifically smart watches, which can track your steps, have really opened up the floodgates for being able to prescribe and measure people's physical activity and encourage them to increase their activity. And the main question is, well, is this an effective methodology for increasing activity, and are there any sort of health benefits? And is this relative? Can this be shown in people with knee osteoarthritis? So first, a meta-analysis was published in JAMA over a decade ago that showed that interventions, pedometer-based interventions, they didn't have smart. This is before Steve Jobs had the Apple iWatch, and it was more traditional pedometers. These pedometer studies were meta-analyzed and found that those interventions that use pedometers, individuals walked about 2,500 steps more on average compared to a control intervention or control group. And this was statistically significant. And this amounts to about 25 minutes of purposeful walking each day. So that is a pretty large effect. Also in this meta-analysis, it's notable that using meta-regression, they found that those studies that had step goals did the best as well. So it wasn't enough to just give a pedometer to somebody, but you also needed to have a step goal. Now, in terms of more recent meta-analysis showing the efficacy of sort of physical activity interventions, there's a recent study published in JAMA that showed that behavioral counseling to improve in physical activity was helpful to reduce cardiovascular disease risk factors in adults who are at risk of cardiovascular disease. And in terms of older adults, recent meta-analysis has shown for a couple studies that older adults are do increase their physical activity when they wear these wearable monitors or such as an Apple iWatch. Now, in terms of OA, there are fewer studies, but for the studies that are out there, there are a collection of studies that show it looks like there are positive benefits favoring counseling to increase physical activity, though this effect was not shown to be statistically significant. And I do want to just highlight a study done, a preliminary study performed by Callahan at UNC Chapel Hill, who did this brief physical activity intervention for people with NEOA. And essentially, this intervention started with screening people to see those who were not active. Those who were not active were given a brief physical activity intervention. And they were also linked to physical activity sort of resources. And then they were given a follow-up call 3 months later. And this study found it was an intervention-only study, and they found positive changes in WOMAC pain and physical function from baseline to the 3-month follow-up. So perhaps the most compelling evidence to date for looking at walking with regards to pain and function is a meta-analysis that was published recently in the Journal of Orthopedic and Sports Physical Therapy. In this study, basically looked at changes in pain and function across all studies and classified the outcomes in terms of outcomes in the short term, which were less than 3 months, intermediate term, which was 3 to 12 months, or long term, which was outcomes greater than 12 months. And what the authors found was, in terms of pain, they found a statistically significant improvement in pain in the short term for less than 3 months, but not so much in the intermediate or long term. And they also found the same for physical function, that there were positive changes that were statistically significant in the short term, and still positive changes, but did not reach statistical significance in the intermediate and in the long term. I think at this point, it's important to mention that a lot of the work that Rana Hinman and Kim Bennell have done has really illustrated this notion of misconceptions or myths that patients commonly believe who have knee osteoarthritis. And these myths essentially revolve around the notion that walking is injurious to their joints, and there's very little understanding of disease. Rather, disease is thought to be bone on bone, and that surgery is the only thing that helps. And there's been a series of qualitative studies that have looked at this sort of these misperceptions, and it found them to be quite prevalent among patients. So I think it's important to consider when intervening with patients that there is patient education about the misconceptions, and as we call it, myth busting is necessary with patients so that they understand that large studies, and again, I always like to point to Steve Messier's work, that especially when combined with diet, are effective for reducing pain and improving physical function in people with knee osteoarthritis. So perhaps some of you are thinking, well, that's great, Dan. So walking's good, but well, how much should we do? And, can you be a little more specific? And so I will attempt that. And we recently we're actually in the process of wrapping up a study where we did a physical activity intervention. This was for people who had recently undergone knee replacement. And our goal was to increase their physical activity. And we did this by giving them a Fitbit monitor that was worn around the waist. And we told these individuals who are coming to physical therapy to increase their steps between 5 to 10%, 5 to 10% increase per week. And what would happen was the patient would come in, they'd say how many steps per day they walked. the therapist would discuss or agree upon a goal with the patient with how much to increase the steps, and they did this while they're in physical therapy. And then after their discharge from physical therapy, a research assistant continued to call the patients once a month for the next 6 months. And what we found with this intervention, this very preliminary data, was that the basically on the y-axis is the number of minutes in moderate to vigorous intensity physical activity, and on the x-axis is our major time points. We have the baseline discharge from physical therapy, 6 months after physical therapy discharge, and 12 months after physical therapy discharge. And the first line you see here is our control group, which essentially had not too much change overall. And this average amount of physical activity that our control group did was consistent with what people with and without symptomatic knee osteoarthritis have been shown to have in general. And our intervention group did have a nice bump in their physical activity at discharge, and this was partially maintained at the 12-month follow-up. And what's nice about this is they were averaging about 150 minutes a week of moderate to vigorous intensity physical activity, which is consistent with now it's the 2018 physical activity guidelines from Americans, published by or recommended by the U.S. Department of Health and Human Services. In terms of steps per day, our control group increased their steps per day somewhat from 2,000 to about 4,000 steps per day. And our intervention group definitely got a good bump and walked to about 6,000 steps per day. And that is a notable number as work that Tuhina and I worked on, I guess several years ago now, where we found that 6,000 steps a day was a threshold that discriminated people with knee osteoarthritis who developed functional limitation 2 years later from those who did not. So this intervention seemed to show positive results for increasing the daily walking to a level that hopefully would be protective from developing functional limitation later on. And just as a quick throw in, I got this card in the mail from a patient who I swear I didn't ask her to send this. She sent this on her own. And my research assistant, now she's a postdoctoral fellow, Hurl Master, sort of helped organize the study. And this was written to both her and I, and the patient said, thanks so much for changing my life. And I think what's notable is that she says that I've gone from a mostly sedentary existence to being an active person. And she says, I think I was in denial about how little I moved, but the Fitbit doesn't lie. And I think in a sense, that's just from a practical perspective, that Fitbit or pedometer just gives an objective measure of how much people are doing. And they get a quick sense of when they have their good days and when they have their bad days. And there's a nice objective measure attached to that. So that's the end of my formal talk. And I provided references for those of you who are interested in learning more about the studies. And I think at this point, I'm happy to answer any questions that people may have. And I think, and correct me wrong if I'm wrong, Leigh, but this is where you're moderating, and then people put in the chat whether they have questions, and then I
Yes.
try to answer them. Okay.
You're absolutely correct.
All right, great.
Great. Thank you, Dan. And it's great to see you just active there and doing your daily life.
Yeah, trying to make it.
Wonderful presentation. So we now have, I think everybody, starting from Jason to Tuhina to myself, we've all gathered a little time, which is nice. So we will have plenty of time for discussion, and the questions are coming in. So you gave us a really nice overview, and I'm going to start with the first question that came in. Do most of the studies mention focus on the knee, or are there also some benefits for hip and back?
Yeah, that's a good question. The meta-analysis that was published in Journal of Orthopedics and Sports Physical Therapy used individuals who had chronic musculoskeletal pain. So it could be in any of the joints. So not just the knee, but could also include back and hip. So it seems that the benefits of walking are not unique to the knee, but to certainly individuals with musculoskeletal pain in a variety of joints.
Great. And that's a nice segue into the next question, which was the same question that I was thinking. Does that meta-analysis address adherence to walking after observing the loss of effect beyond the 3 months? Because you said really at the short term, people had a positive impact and then things tailed off. And did they look at adherence, and were the benefits sustained if people continued walking?
Yeah, no, that's a great question. And they did not, to my knowledge, they did not meta-analyze adherence. But I think the common clinical belief of what happens is people they tail off at the end, and so the effects that you see that are mitigated over time are not so much a loss of potency from the walking, but people just stop walking. They need to it's when we talk about permanent behavioral change, it is challenging to get that. And the good news is if you can do it, and this is what um, Steve's work is just so powerful, is that when you have them come in for 18 months, you see those gains and you see them throughout. But once people are left, it is challenging to have those gains sustained because of the behavioral nature of walking interventions, and constant encouragement and figuring out how to make permanent behavioral change it, is the golden thing we're trying to go after here, and would make a tremendous difference. But irrespective, I think trying to encourage that initial change, and there's a variety of psychological theory on how behavioral change happens and sort of the stages of change, or transtheoretical model you can use to model this. But it is important that it is a dynamic behavior is dynamic, and constant encouragement is incredibly important.
Yes, and Shannon Mihalko, who's a big part of Steve's group, she has focused a lot of the work, Steve's work, on the social cognitive theory and really trying to change self-efficacy. But the same issues that come up around physical activity come up with weight loss maintenance.
Mm-hmm.
And
yep.
You're right, it's the golden thing. If we could figure that out, that would help a lot.
Yeah, absolutely.
Everything. And so trying to think about that is important. Okay, I've got another question here that sort of gets into what we were talking about too, about should trials consist of complex interventions, walking, exercise, and behavioral interventions?
Yeah, that's a good question. I think, my bias is to have practical, pragmatic interventions, since we know we have a sense of what fundamentally that walking is beneficial for pain and for function, especially when included with weight loss. So I think complex interventions are, we rarely in our line of work do we give single modalities out to patients. We give multiple modalities. I even alluded to this when I talked about the importance of misconceptions and myth busting with patient that comes from Kim Bennell and Rana Hinman's work from Australia. And so, yeah, if there's a way, it's probably not going to be one simple thing that we need to switch, but multiple things. So understanding what those, providing practical interventions that address multiple areas, I'm fully supportive of. Leigh, I'm not sure what you think, but I mean that's
I completely agree. And if you think about it from when we just think about what we recommend from a public health perspective, we recommend 3 things: self-management, weight management, and physical activity. And it's just one or the other. And it's thinking about how those become packaged and sustained or maintained is important. So the next question I have is, how reliable are the data given by the Fitbit?
Yeah, that's a good question.
And
I
I'm
don't
going
have
to
this.
add a question to this.
Sure.
And does it matter if how reliable they are if it's pretty consistent within the same person?
Yeah, there have been some studies that have looked at the Fitbit in comparison to research grade monitors like the Actigraph or the Actipal, and the Fitbit actually does pretty well. I won't go into bore you with the details with the specifics, but I think from a clinical perspective, it's it is a very clear reminder to patients of where they're at, and using if the the validity perhaps is not so specific or so accurate with the exact number of steps per day people take, but it relatively measures the same within a person and is a very a useful tool, per the literature to date. So I encourage people to use it more as an index of their physical activity rather than a literal here's exactly how many steps you've taken. Make sure they're not putting it on a dog or a sawzall to get their to get to their steps, but to use it as an index, and that they want to reach that, and that's where customized goals to get people to where they need to go are incredibly important as well.
Could you comment a little bit while we're talking about that on the role of accountability and how the Fitbit ties in with accountability and the impact of?
Sure. These monitors to date certainly can incorporate a variety of strategies that are consistent with behavioral change techniques, and there's been a couple papers on this that show that things like instant feedback are important, but then there's more advanced tools you can get, such as rewarding for goals, which can be done with the Fitbit. And then in terms of accountability, you can send your steps to your friends and relatives. You can post them online. You can do all sorts of different incentives to really help people. Well, to help yourself essentially become more physically active. And the there's I think, and maybe this comes back to the question of complex interventions. It's probably not the same thing that's going to work for every single person. It's going to be different combinations, and the more tools you have with a monitor that you can leverage different things, and the more effective it is. And I think our job as a research community is to better understand what are these different lever points we can pull on for patients, and begin to sort of differentially diagnose people not by their disease, but by what strategies may work best for them. Because you might have the social group, that does great with the rah feedback to get them going, and then other people might be more of like, I just want to know my steps and I just want to put my head down and get it done. And so understanding what these different phenotypes of exercise are, I think it is really the next phase for our research enterprise, in general, for thinking about physical activity and NEOA, as well as understanding what these other areas that patients are thinking in terms of myth busting, and encouraging them to move forward.
I think you're absolutely right. And we've seen that with the program Walk with Ease. When we did the initial studies, we didn't randomize people to group or self directed, because there's some people who like to be in groups, and there are other people who just, like you said, want to put their head down, do their walking, or either they have challenges and barriers in their life in terms of accomplishing it at the time that the group course is being offered. And speaking of barriers, the next question is, what's the biggest barrier preventing buy-in from physicians and or patients for walking as a treatment intervention for osteoarthritis?
Yeah, that's a great question. A recent I had a doctoral student who recently graduated, Meredith Christensen, who did a nice qualitative study at the University of Toronto and asked, primary care physicians, essentially, why aren't you recommending exercise? Why to people with knee OA? That, very, she didn't phrase it that way, but essentially that's the question we're going to ask. And the answers were actually quite interesting from from, again, this is a qualitative study, hypothesis generating, but there's sort of several themes that came up. One was the notion that exercise is not a real treatment. That it's, medication is a treatment, but not exercise, and certainly not walking. Two, the physicians didn't feel they had enough knowledge in the area for what to prescribe. There was a hesitation with, well, I don't know how much to recommend. So sort of a knowledge gap existed there. And three was just a lack of resource to refer somebody to their patient to someone who is knowledgeable in exercise. That there was, they knew exercise is important, but they didn't have like a clinical partner, such as like a physical therapist or even just a regular trainer that they could trust to refer their patients. So again, this is a qualitative study. It's hypothesis generating, but sort of rings true to, it seems to make sense with what's going on from the physician's perspective. From the patient, I'm sorry, go
I was
ahead.
just going to ask a question. So when you said in the three things you first started it out, that they don't think of it as a real treatment, and so that was even the physicians didn't think of exercise
Correct.
as a real
Yes.
treatment. Okay.
Exactly.
Great. And now to the patients.
Yeah, and so from the patient's perspective, Meredith did a qualitative study looking, asking patients, what they thought of what their experiences were with physical therapy and what they think of exercise. And the the major theme that came out with that was that exercise couldn't help because they were told their disease was bone on bone, that surgery was the only thing that could help. So it's a complete misunderstanding, which it's unclear whether it's from the patient's perspective or the provider on the patient, but that, that again, similar thing as the physicians were saying, exercise is not a real thing. And it's not effective for their condition because they're totally too far gone, which, is true for some patients, but not the vast majority of patients. And so this is where, I like to talk about Rana Hinman's work looking at this, it's called the PEAK trial, which is this telehealth program for physical activity for people with knee osteoarthritis that has interwoven in it pain science and education about disease, and frankly, a lot of myth busting over misconceptions of how disease is perceived and what the benefits of exercise are. So that's my understanding of what we've learned from patients.
Great. Well, let me just wrap up with a few final questions that I think will be quick, and so we can move on to the posters. Well, one was a comment. Someone said to get my patients started, I suggest 10-minute intervals. And one was commenting on that research of 10-minute intervals.
Yeah, the physical activity guidelines used to say that physical activity needed to be bouted, that is continuous in nature, and the 10 minutes was the first threshold for that. They've since removed that requirement. I think in any duration that a patient could be successful is a great place to start. If you can get them to go for 10 minutes, fantastic. It's also notable that, those 10 minutes they're doing something is also they're breaking their sedentary time, which we haven't talked anything about sedentary time, but this is a whole new area of research that's emerging that is a real paradigm shift from thinking about just physical activity as being exercise, but also considering the downtimes and the impact of that. So having those 10-minute breaks from sedentary time or starting 10-minute intervals of exercise is a very practical and makes a lot of sense to start with.
Okay, and the final one, and then there are a few comments that I think the comments will be available for you to respond to people to as well. But the final one I'll ask in this session is strength training. Does it matter that that it is specific to the affected joint, or are there generalized metabolic effects, and how does one separate which is beneficial?
Yeah, I don't know what the last time I looked within the past year for how strength training, it's unclear what the mechanism is with how that is so effective with NeoA, other than we know strength training increases strength. And there's some biochemical sort of cascade events that happen after strength training, and certainly being in shape, that there are general health benefits for that. But how that exactly works with NeoA, we are not. I mean, I'm not aware that we really know that mechanism. But there are countless studies, and I encourage people to read Marlene Franzen's meta-analysis, or Cochrane review, looking at land-based exercises, which includes a lot of strength training exercises that show, efficacy for people with NeoA overall, and so that does include the affected joint, and as well as you get the generalized benefits of strength training, which I guess the last thing I'll say is that it's important to consider not only the aerobic component of physical activity, but there's also a strengthening component, which we all should be doing strengthening at least 2 times a week. So, having strength training certainly checks that box.
Thank you so much, Dan. This was a wonderful overview about walking, and I think generated a lot of thoughts and comments, and a great way to launch this afternoon on physical activity. And I really appreciate your presentation, as well as the great responses in the discussion.